Hello, my name is James Waldron and I'm a portfolio GP working in Nottingham and the first 5 lead for the Vale of Trent faculty. And I also co-host the GPnotebook study groups. Welcome to the GPnotebook podcast, where we discuss bite-sized topics aimed at all of those working in primary care. You can find us on all major podcast platforms, including Spotify, Apple Podcasts and Google Podcasts. Please follow us to receive notifications about new episodes. And if you like what you hear, please consider leaving a review to help others find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups. Finally, you can visit GPnotebookpodcast.com for podcast episode show notes and GPnotebookeducation.com to find out more about upcoming study group meetings. In this episode, we'll be discussing dermatology, and I'm really happy to be joined by Dr Thuva Amuthan, who is a fellow First 5 GP, a GP with special interests in dermatology. He's also known as Dr Derm, and he's a keen educator in all things skin. Welcome, Dr Thuva. Great to have you.
Hi, James. Thank you. It's great to join you today on this podcast, and hopefully we'll be able to talk a little bit about dermatology and see what I can do to help.
Oh, that's brilliant. Well, we're really grateful for your time today. So I suppose to start off with, tell us a little bit about yourself. How did you become a GP with interests in dermatology? How did you get into that?
That's a very interesting question. I think, I've always liked dermatology for the way, that you get to add in the visual element and the practical hands-on element, and it all goes in well. And how I ended up in dermatology was when I was doing my training, I happened to start up a business doing some aesthetic work and got into that. And then, all of this just tied in really well. And so I was enjoying that. So I thought, let me, venture into dermatology, bit of minor surgery. And that's how I've built up what I have at the moment.
Yeah, brilliant. It's really exciting because I understand you actually run, or at least a part of a community clinic. What sort of things do you see in general practice dermatology that you might not see in usual general practice?
Yes, so I do work for Modality Community Dermatology Service, which which serves all of Birmingham and Black Country area. Now, in community service, the things that we kind of tend to see are acne, where patients need Roaccutane, we're able to manage that. Eczema, psoriasis that are not well controlled, hair loss, all sorts of hair alopecia, warts and verrucas that are not being successfully treated. Fortunately, there's not an awful lot we can do either, but we have a look and see if there is anything we can add to that. Pruritus, urticaria, benign lesions, some lesions that are maybe suspicious but in doubt, that are not that do not meet the fast track criteria. Pigmentation, sometimes scarring, cyst, ingrown toenails, fungal infections, all sorts really.
Well, there are a huge number of things by the sound of it, so a heck of a lot to cover. Well, I was wondering if there was anything in particular that you might see in your clinic that could be treated a bit better, that we might manage a bit better in, I suppose, general practice. Do you have any tips for us?
Of course. As we say, as generalists, we know a little bit about everything, and it tends to be that GPs are actually really good at skin. So we do a really good job in general practice of managing these things, given that 20% of our consultations are skin and hair related. Now, of course, there are things that are common. Most common things that we see are acne, eczema and psoriasis, and I think that's what the focus can be in terms of if I was to give you some tips and hints as to how to do a better job at that, so that one, you have to refer less patients, and two, patients have better outcomes after all.
Yeah, well, that's brilliant. I'm thinking straight away about eczema, because we see a huge amount of it and often treated in general practice. What sort of things do you tend to see that we could do better in respect to eczema, and what is it that we can really help our patients out with?
That's again a very good thing there. Yeah, eczema it tends to be quite a bulk of what we see. Now, we don't do anything special in community dermatology apart from reiterate compliance, because, that's what it comes down to. The doctor can give them all the magical wonder drugs possible, but if they're not using it properly and making the most of the medication, it's pretty useless. So I really would just take it back to basics in community dermatology. The way I do it is I ask them I put it on themselves. I say, what's your routine? How are you managing? Because most of these patients, you've got to remember, have been dealing with it for decades plus, if not longer, since birth.
Yeah. So routine wise, I mean, what sort of routine should they be looking for? Where do you start with eczema, taking it back to basics?
Yeah. So with eczema, I really just literally, when the day starts, what do you shower with? You know, what are you using? You'd be surprised how many people with severe eczema are still using soap to wash with in this country.
Soap?
Yeah, soap. Yeah. And then, that is a disaster sign for eczema. It's not really going to help your eczema at all, if not make it worse, in fact. So that's how, as basic as I go. So I start and literally spell out a routine and figure out what they're doing on a day-to-day basis that could impact their condition. And that may be an opportunity for us to help improve their condition. So that goes back to literally what they wash with. And then I ask them, so your doctor's giving you this and this and this. How long have you actually used it for? How many times have you actually used it for? How much have you got left? Because that might be an indication as to whether they're fibbing or telling the truth as well.
Well, that's it, I suppose. How long does your Cetraben last for? If it's 6 months, probably could be using some more.
Exactly. And then that's what I come on to afterwards. So after you put steroids, what emollient do you use? And people are like Nivea, and they've got severe eczema. I'm like, I know Nivea is not bad at moisturizer, but you've got a medical condition that needs emollients. And they're so like, and some of them are like, oh, I might moisturize once or twice a day, doctor. I've got a busy job. I'm like, so I say, if your condition is that bad, you need to get through a tub a week. If you're not getting through a tub a week, that's not good enough. And I tend to over egg it, because we all know what you say they will dilute down in practice. And I don't blame them for it. We're the same. We're human beings at the end of the day. If you're told to do it 5 times a day, you might do it 3 times a day. So I tell them to do it 5 times a day, because they will do it 3 times a day. That's as practical as I try to get.
Yeah, well, that I think it's a really good idea. I hadn't thought of kind of over-egging it, saying you 5 times a day and hopefully they do it 3, because if you say twice, they'll do it at once or every other day.
You're right, absolutely, yeah. And you think about it; these patients have been doing it for 10 years, and it comes back to basic education.
Yeah, education super important, and I think taking the time, particularly when people are younger, so that they kind of get it into their routine. Because I mean, do you see much complications? Do you see much long-term issues with poorly controlled eczema?
I think eczema has a huge impact on life, especially if you're an adolescent or a child. That being at school, you're bullying and all those things. It's a horrible thing to live through. The psychological impact of skin condition is so huge that there's a new specialty that's developed called psychodermatology, if you believe it or not. And it's going back to the original point in terms of emollients. Like I said, I say tell them to do 500 grams a week if possible, and 5 times a day. And I tell them, the steroids that we give you is only a temporary plaster. The real treatment is the emollients and your routine. If you get that right, you're not going to need the temporary plaster. The plaster is a plaster. It's not going to fix the issue. You need to, if you want to feel better, improve your condition, then you need to manage the condition, and your management is emollients, because your skin's lost its moisture. You need to replace that moisture, more so than someone who doesn't have eczema. If you don't do that, you're going to have to struggle with this for the rest of your life. And like you said, it has this huge implication, especially with lichenification. Cosmetically, it doesn't look nice, especially when it's around your neck, around your face. And you can imagine if it's affecting your areas around your eye, which can sometimes happen, you can hardly do things on a day-to-day basis if it's that bad.
Yeah, no, I can quite imagine. And I think impressing that on people early seems to be the key, and particularly this idea of not using soap, because I think that's that must be quite an alien concept to people. What is the I've heard this before on other talks. What's the particular danger of soap? What's the issue there?
I think the principle is that it's dehydrating, isn't it? What you want, as in washing in itself is dehydrating. So the other thing I hear is some people who come in with showering 2 to 3 times a day. Every time you shower, you're losing moisture. So the act of using an emollient as a substitute is to cancel out that effect. It doesn't make it better. It just cancels out. If you use soap, you're not only sucking moisture out yourself by showering, but the soap also dehydrates you. So it makes it much worse. That's my understanding of it anyway.
Yeah, that's it. Brilliant. I mean, so obviously we've covered eczema there in quite a bit. What sort of other things do you see? What sort of other things tend to turn up at your door that we could do better at?
One of the other things I think is acne. I think, we all know dermatological education doesn't really find a footstool in general practice training. Unfortunately, it's not given the due merit it does. If you think about it, 20% of consultations are a thing, and acne is another forefront in terms of psychological impact, especially for children who are, teenagers who are having and suffering from acne. So I think that's something that we can improve on for sure in primary care. Most of the times, most GPs manage them really well. We know topical therapy. If that fails, then on to oral tetracycline for up to 3 months to see if it's any different. My general principles is that I tend to use something called Treclin, which has got tretinoin and clindamycin. It's a dual therapy for topically, and see if that works in the lightest of acne, in the mildest of acne. If it's moderate or severe, I tend to go straight on to an oral antibiotic. Now, there's, of course, the debate of antibiotic resistant. Is that the right thing to do? But it's a balance of psychological impact versus antibiotic resistance there, isn't it? And as a rule, we say 6 to 8 weeks is when you should start to see a difference on oral antibiotics. Any less than that is pointless. You've not given it the time for it to work. And 12 weeks is probably the mark where you assess as to whether you should continue or refer on to a dermatologist. Even 8 weeks, if it's not working, I would consider referral, because then we will consider either stepping up to Roaccutane or another antibiotic to see what can be done. And another useful thing to do is, if you do the bloods beforehand for Roaccutane, which is your LFTs, lipids, and an FPC, and using these as well if you can, then that'll be really helpful, because when they come to the first appointment, we might be able to get them started on sooner rather than later.
Yeah, that's really good. I mean, and again, you mentioned this holistic assessment of people with long-term skin conditions and acne as well. That's really important to help people understand where they're going to be and to prevent some of those long-term complications that they often run into. I suppose the third one you mentioned earlier as well is psoriasis. And I think you see quite a lot of that. How could we be doing better? Well, again, education-wise, how can we be educating our patients better so that they get better outcomes?
Yes, you're absolutely right. Psoriasis, again, is a quite predominant condition in the population, believe it or not. And, I think, GPs are quite good at picking that up. Now, the red herrings that you need to obviously watch out for is palmoplantar pustulosis, or psoriasis that affects your palms and your feet. That needs an immediate referral to us, or if not, the hospital if it's severe enough, because we will try some treatments. If they don't work, then they need systemic therapy, which tends to be only done in secondary care. So we can either assess and then refer on, or you can refer directly on. So that's one of the biggest thing about psoriasis. The other things is to look for subtle signs that we tend to do is psoriasis can affect behind the ears, and you can get nail signs. That's a giveaway for psoriasis. And the other thing to remember in psoriasis in terms of tips is that calcipotriol or vitamin D analogs, if there is no scale, will make it worse.
Oh.
Yeah. So if there is no scale, it's better to use just steroids, or at least counsel the patient that it's going to get worse before better with psoriasis. And again, with psoriasis, it's pointless trying to use steroids and all these things trying to treat it if you're not using the emollients, not showering with the right things, because it's not going to get better. It's not going anywhere.
Back to the emollients, super important. And again, through talking to you this, I think I'm going to be stepping up the emollient use and telling people to use it twice as much as they should be to hopefully.
Absolutely. And the other thing to remember is psoriasis typically, especially palmoplantar psoriasis and things, affects harder areas of the thicker skin, typically your palms and feet. So you need quite a potent steroid to penetrate that. If you can either try that. So typically I tend to go for betnabate or stronger on the body, as long as it's not above the clavicle, or just refer on to us and we'll consider a stronger steroid. And the caveat, I think the other caveat I'll add is be cautious about giving oral steroids to patients with psoriasis, because you get a rebound flare.
Oh, is that right?
Yeah,
Gosh.
that's something we've learned not to
Yeah.
do in some ways. Yeah.
Yeah, no, I understand. Do you think that, I suppose the question that jumps to mind is, do you think that GPs treat these conditions sort of vigorously enough before they refer them in? I suppose my first question.
That's I think I think overall GPs we're pretty proficient in the way we treat skin condition, psoriasis and eczema typically, and acne in most cases as well. But of course, there's always room for improvement. But again, like I said, the only difference is that I guess in my clinic, I get 15 minutes with a patient, whereas in general practice, you only get 10 minutes with a patient. And sometimes that's not even 10 minutes because you might have to save on that appointment because you're dealing with a mental health appointment next. So, you have to be practical about this. And the only difference, the big, apart from the stronger but steroids I might consider or treatments I might consider, the only other difference is reiterating the practical lifestyle adaptations and the use, and literally it's almost an interrogation, not really, but you know what I mean, in terms of what are you actually doing and what have you actually used, what has actually worked for you.
Yeah.
And again, understanding what their goals is. Why do you want to do this? Why does it make a difference to you? Because if it's affecting their work, it's sort of a bit of a motivational interviewing, isn't it? All
Yeah.
those little tips that we do in general practice, which we're very good at, I think
Yeah.
that's what makes those difference. But unfortunately, sometimes we don't have the time in general practice to do all those things. So I think if ever you're in question or in doubt of the diagnosis, refer. And then typically we tend to manage them and get them on the maintenance plan before we discharge back to them. And you always have that to refer back to in future if there's subsequent flares, that you can just refer back to that plan. And so I guess the point of note is, if they've seen a dermatologist before, have a look at that clinic letter and just copy that and do that. If it works, then save yourself a referral. And the patient might be happy as well with that.
So coming on to psoriasis, a commonly encountered issue is figuring out how to use the different creams, vitamin D analogues, steroids, and cycling them and using them effectively for patients. Do you have any advice for that, as we come across quite a lot of different approaches? What do you tend to do?
So I think you get lichenifications or thick skin in both eczema and psoriasis, and standard emollients are good, but you might need to then step up to urea-containing emollients because they will suck a lot more moisture in. So like Balneum Plus or Flexitol, I think Flexitol is it. Those tend to be more moisturizing and can help with skins that are breaking down or skins that are really lichenified. Now, when it comes to psoriatic plaques, what you might then need to consider, for example, in the scalp, is something like Cocois or Sebco ointments, which can break it down. And now in the BNF, if you look at it up, it says you can use it daily for 7 days and then once a week. But obviously, it's really messy, so the patients don't like it. But it's the only thing that's going to break through that scale, because however potent steroid you put on a scale, it's not going to penetrate. It's not going to do anything unless you break that scale. And I really do spend that time explaining to the patient. And then they're like, okay, fair enough, doctor, that makes sense. So I really do have to break this up. And I'm like, yeah, you do really have to break it up before we get anywhere. And then they're like, okay, cool. And then they do that. The other thing, a case that I recently had in practice where my boss had a quick look and advised me was in patients, who are frail, elderly, living at home by themselves. And you're unsure, even despite that advice, compliance is going to be a case. Keeping it simple. For example, he had quite bad palmoplantar psoriasis or pustulosis, if you can call it, a lot of scale on both of his palms and both of his feet extensively covered. And we just went to a simple diprosalic, I think it's got bentonate and salicylic acid. So salicylic acid will act as to break down that scale a bit more aggressively than urea or emollients or Cocois even do. And the bentonate will act as the steroid to dampen down that the inflammation in that case. And I guess the other thing to consider for body or truncal one is Enstellar foam. Foam works better than cream, and the Enstellar foam is got the analog and the steroid in it. But again, the word of caution there is, if it's no scale there, it will make it worse.
Yeah. Well, brilliant. I mean, I think there's an awful lot to think about there. And the things I'm going to particularly take away from this is the use of emollients and, again, trying to break down that scale. And the third thing is educating the patient and thinking about the impact long term, I think is the thing I'm going to focus mostly on after this. I mean, one of the things that we're going to talk about in our next conversation for the next podcast is about some of the long-term impacts in people with coloured skin. What just kind of gives a bit of an overview as to why that's important to think about that and why you should tune in for the next talk.
Brilliant, thank you. I think it's a topic that's passionate, that I'm passionate about anyway. I think historically the literature and training has always focused on Caucasian skin because that's what is in the textbooks, etc. So I think colored skin has sort of been dismissed or not studied well enough for us to understand how conditions present, how we should be managing them, and the consequences and complications that occur in that colored skin. And unfortunately, as we know, mixed race is the ethnicity that's growing the fastest across the world. And so we're going to have to take care of this population. And I think with a metropolitan population we have across the UK now, with the diverse society that we have, it's important that we address this inequality, because it is what it is. It's an inequality and it's only getting worse. And we have to pay it due attention to address that. And hopefully we'll be able to shed some light on that.
Brilliant, and I understand you have the Black Country Skin Club, which you do education events for, and I think maybe we can link some of that in the information surrounding this.
Yes, that's right. Black Country Skin Club is something that I've hopefully set up to help educate our colleagues in primary care and community dermatology and secondary care, to bring us all together to learn about dermatology, because the only way forward is, we all know we have to do CPD for appraisals anyway, right? So why not do it over a fun networking event where we get to meet? So we're going to do that last Wednesday of every month, one face-to-face and then one virtual. So everyone across the country is welcome to join. So Google Black Country Skin Club and you'll be finding the link to join.
Brilliant. Well, thank you so much. Thank you so much, Thuva, and I'm really looking forward to the second of our talks, which is going to be on dermatology in skin of colour. And so you should be able to find that very soon. So I think that's all we've got time for today. But hope you can join us the next time round. Thank you very much, Dr. Amuthan, and hopefully see you at the next podcast. Thanks.
Thank you, Dr. Waldron.
Cheers.
Appreciate that.
Cheers. So thank you all for listening. We hope you found this podcast helpful. Please do have a look at the show notes that accompany this episode at GPnotebookpodcast.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email support@gpnotebook.com if you have any questions, comments or ideas for future podcasts. You should also visit us at GPnotebookeducation.com to register for our virtual GP Notebook study groups and download free resources and shortcuts to help improve the lives of our patients in primary care.